Thank you. Also for me, it's the last talk in this wonderful Congress, and I thank you for the invitation, being here. So we study with the robot and the cadaver knees, the kinematics of knees where a uni or a double uni have been implanted. These are my disclosures, and this investigation was supported by Zimmer Biomet. After my application, we have done this in Zurich University. I have no financial interest in this investigation. So we are talking about uni or a double uni. And the rationale is that we want to achieve with our plastic and metal the ideal condition of a forgotten knee. The natural knee kinematics, we all know that is reproduced or is done by the existence and the good function of the central pivots, so the anterior and posterior cruciate. And so we have hypothesized that a uni or a B-uni can closely restore the natural knee kinematics. And this is very well demonstrated in the literature from the clinical viewpoint, as in this paper of German colleagues. And you can read the knee, the uni-loaded knee closely resembles native kinematics. And also the B-unis compared to the unis, they do well. If we respect the both-cruciate ligaments, we can achieve a result as good as in the unis, according to the same group. And according to this group, if we implant two unis, we can at least have the same results of a total knee arthroplasty. But these are clinical papers, and we would like to demonstrate that the function of the knee with a uni knee, with a uni implant, can be very similar to the intact knee kinematics, and this is the first question. The second question is the same thing for the B-uni, so the B-uni replacement does the same. And we have adopted the existing computer knee modeling technique, the virtual bone modeling with a KUKA robot, I will show you, and can be extended. And also the information obtained with this technique can improve the surgical technique of uni and B-uni. And because at the moment, mainly the B-uni, it's the art of the surgeon rather than a standardized and reproducible procedure. And this is the KUKA robot, and this is one in the US, another one is in Zurich. So we start from a cadaver leg, and this is X-rays, and they are mounted here, and they are tested in the KUKA robot. Then we have implanted a uni or a B-uni, and the knees have been retested until the end of the procedure. And this is how a uni can, a normal knee behaves. You see, you can hear right here the flexion, and this is the femoral AP translation during flexion of a normal knee, according to the investigation done with this robotic investigation. And you see that AP translation decreases according to the increased flexion. And this is my co-author, Sébastien Parrat, and we have done this investigation together, and here we are working in the lab. So the first part is concerning the unis, and you can see here that we have robotic tested the intact specimens, then we have implanted the medial uni, and then we have retested the knees. These are the specimens with the age of the donor, the height, the BMI, and so on. And we have looked at the flexion between 0 and 100 and 120 degrees of flexion, the internal and external rotation, the varus valgus, the AP and ML at low and high compression forces, and we have simulated lunge, level walking, and stair descent. This is one knee with the implanted uni. So if we look at the varus valgus stability of the knee according to the flexion, this is an intact knee. Look now, we've done the same thing after the implantation of the uni. That's the name of the uni we have implanted. You see the the kinematics is absolutely overlapping. And this is a varus valgus balancing, and this is the average of all specimens. So the blue line, intact knees, the red line is the knees, other knees with the uni implanted. So we had a very close match between uni and intact group. The same thing for the medial and lateral opening, with a constant medial opening across the bull arc of flexion for the uni. And this is because we got a little bit more varus after the implantation of the uni compared to the intact knee. And this is according to the technique. And this is a hyperextension. So we got 1 degree more of hyperextension. But you see that the flexion of the knee are exactly the same before the implantation of the uni and after the implantation of the uni. And this is an example of the AP stability and rollback of the intact knees and the unis, and this is the average of all specimens. You can see that the curves are completely overlapping. So the AP stability and rollback were maintained under low and high compression forces. And this is the lunge. And this is a patella kinematics during passive flexion, the intact on the left and the uni on the right. And again, the tilt and the medial shift were exactly the same in the knees. The second part of the investigation was with the 2 unis. And this is an example of a cadaver knees where 2 unis were implanted. We got 10 knees. That's a demographics of the donors. And the color-coded blue is the intact knees, only 1 uni, 2 unis, and 2 unis with the resected ACL. So in the same knee, and the same knee has been tested without any implants, with only 1 implant. Then we have implanted the second one every time the knee has been retested. And the final trial was after the resection of the anterior cruciate. Exactly the same protocol of evaluation. And if you see now the laxity test under low compression, the AP laxity is almost the same. Intact, uni, and 2 unis. Rollback, almost the same. Intact, uni, and 2 unis. And this is the AP laxity under low compression. This is a knee without any implants, and this is a knee with 2 implants. And you see that the curves are overlapping. Under high compression, we had a decrease anterior AP laxity and a decrease rollback, and this is again due to the presence of the metal and to the surgical technique. Looking at the flexion facet center, so the center of sagittal curve of the posterior condyles, and this is important in this test because we are looking at the motion of the femur compared to the tibia. We can see that at low compression, the flexion and the lateral facet, or the flexion and the medial facet of the condyle are more or less the same. There is a discrepancy when we have cut the ACL. This is the knees with the ACL cut. So we got there a lateral, more posterior inflection. And the high compression, this disappeared almost. You can see up there. And the curves are almost the same. So that means that under high compression, the importance of the ACL is not so important. This is the lunge, and we got less lateral rollback after B-uni. And you see this, in descending the stairs, how important it is to have the ACL, because with the ACL cut, we have a very dynamic instability when we accept the load, when the knee accepts the load in descending the stairs. And again in the level walking, look, the average anterior-posterior, this is a medial condyle, and this is again the lateral condyle. So in conclusion, according to the 4 questions in the beginning, the first point, the function of the knee with a uni knee is very similar to the kinematics of an intact knee, and closer to the function than a knee with a total knee arthroplasty. Yes, we can say it's almost identical. The function of a knee with a B-uni, again, is very close to the normal knee, yes. The function of the CL is absolutely important, and we have seen that it is. The information can help in improving the surgical technique, yes, and we have demonstrated that we have more technical independence for the B-uni. And thank you for your attention.